Good evening, everybody, and welcome on this cold, windy, wet evening to another Meet Our Consultants. Today, I'm delighted to welcome Iain Yardley, obviously consultant, neonatal and paediatric surgeon at the head of paediatric surgeons at the Evelina London Children's Hospital. So, Iain, thank you for joining us tonight and giving up your time. As per always, we've got lots of questions which have been submitted to the office prior to tonight, which obviously Iain's had a look at. And what we have done, because we had a huge amount of questions, is we've collated a lot of the questions sort of into one sort of category, which we're going to talk about, but we will obviously make as much reference to personal questions as we can as we go along. Obviously, you've got the chat function. If you've got any other questions, I cannot guarantee that we'll have time to ask them. But if we do get time towards the end, then we will do so. But we'll carry on and obviously talk about that as we go along. So without further ado, I'm going to hand you over to Trace, who's going to ask the first set of questions. Trace.
Brilliant. Thanks, Duncan. Hi, Iain. Okay, first question is, what is reflux and why is it worse in OA and why is it important to know about it?
Yeah, I think that's a really good place to start, actually. So we have a sort of shared understanding of what we're talking about. Just before I say anything else, first of all, thank you for having me. It's a real privilege, and TOFs is a group that I have a huge amount of time for. Of all the conditions that I treat, TOFs is by far the best patient and family support organisation. So kudos to you guys. Really, really impressive what you're doing. And the other thing to say is, please don't take anything I say tonight as being clinical advice, because I don't know you. If you were born with OA TOF yourself, or your child if you're a parent, but hopefully it'll be helpful and will help you understanding and help your conversations with your clinician. So that said, what is reflux? Well, we're talking about gastro-oesophageal reflux here. There are other kinds of reflux too, reflux into the kidneys, but we're talking about gastro-oesophageal reflux, which is when the content of the stomach goes back up into the esophagus. And that, it should be noted, is a normal phenomenon. Everybody refluxes to a certain extent. And it's actually important that you can reflux. Because if you can't reflux, then you can't burp and you can't be sick when you need to be sick. So reflux in and of itself is normal, and it only becomes a problem when it becomes excessive and starts causing either symptoms or damage to other structures. Now, it's worse in esophageal atresia because, as you all know, the esophagus hasn't formed, and so there's a disruption in the esophagus, and it's obviously shorter than it should be. And so part of the surgical procedure is bringing those ends together, which inevitably involves pulling up on the bottom end to a certain extent. And that distorts the shape of the bottom of the esophagus where it meets the stomach and disrupts the normal mechanisms that we have anatomically to reduce reflux. So that's why it's more common and generally more severe in esophageal atresia. And as I've already said, it's important because if it's excessive, then it can cause symptoms. So it can cause discomfort. It can cause chest infections. It can even cause acute life-threatening episodes, particularly in infants, because that reflux comes back up and enters the airway and causes problems there. And chronic reflux can cause damage to the esophagus, can cause reflux esophagitis, because the esophagus is not designed to be exposed to acid like the stomach is. So the stomach has its own protective mechanisms that the esophagus doesn't. So chronic exposure to acid will damage the lining of the esophagus and can cause changes there, either esophagitis or changes in the cells themselves. And there's potential risk for that to turn into something nasty and to even turn into esophageal cancer in later life. So that's why reflux is important.
Yeah. Okay. Great. So thank you. So how long does it last, and can it return if it settles?
Yeah, so that's a really good question, and I know that some of you have been told that your child will definitely have reflux for the rest of their life. Now, I mean, I think some children, as they grow into adulthood, will continue to have troublesome reflux, but actually, it generally improves with time. And there was a study that I actually read when I was preparing for this, and I've now completely forgotten where it was from. But they did pH impedance studies on children at 18 months and 8 years, children with esophageal atresia. And the reflux was much, much better in the 8-year-olds than the 18-month-olds. So there's a general trend of improvement. And there is also a general trend that people are better able to manage it themselves as they grow. So obviously, if you're a baby or a toddler, you don't have the same sort of self-control as an older child or an adult does. And so you won't be able to manage it quite so well yourself. Someone asked if it could come back. Well, yes, it could. But I think that would be a little bit unlucky because, like I said, there's generally a trend towards the gastroesophageal reflux getting better as you get older. So if you've had it problematic when you're in infancy or preschool and it goes away, I think it would be unlucky to have it come back severely. But it can happen. And of course, reflux does happen in people without esophageal atresia, and the symptoms of it recurring would be the symptoms that anybody else would be likely to experience. So perhaps regurgitation or the sensation that something's coming back into your mouth when you're eating, heartburn, that sort of burning sensation in your chest, particularly after eating, is quite common. And a cough at night is another sign that there can be reflux going on.
Okay, yeah, so that sort of covered a little bit, I think, of the symptoms in an infant and the symptoms of the children. So are there any more specific symptoms?
Symptoms in an infant are often quite difficult to tease out because obviously they can't verbalize, they can't say it hurts here. And very small babies, it can be even harder. Most obvious symptom in young children is regurgitation. Do they just bring their feed back up? And any of you who've had babies who haven't had esophageal atresia will, of course, know that that's normal too. It's normal for babies to posset after a feed. But if that becomes excessive, it can cause problems with their growth because they're not able to keep the milk down. Other symptoms are a little bit more vague and can include just general irritability. Some people talk about back arching in a baby, although I'd be cautious of assuming that back arching is due to reflux. I'd need a little bit more than that before I diagnose the baby as having reflux. And then, as I've already mentioned earlier, they can indeed have acute life-threatening events where they stop breathing. They have apneas and go blue, which can be obviously extremely distressing, absolutely terrifying for parents. But we should note that there are other potential causes for acute life-threatening episodes. So again, even in a baby with esophageal atresia, I wouldn't automatically assume that was because of reflux. There are other things such as tracheomalacia that could cause that. But they're the symptoms that you might see in an infant.
Okay. Somebody's just asked on the chat, is dribbling the symptom of reflux in infants?
No, not usually, I wouldn't have thought. I can't see why it would be. Obviously, some babies are just more dribbly than others, aren't they? Obviously, when they're teething, that gets worse as well, doesn't it? But no, I wouldn't put dribbling down to reflux.
Okay, thank you. I think Duncan, so symptoms in older children, do you want to cover that any more, Iain, or do you think that?
Yeah, so we've as you said, we've talked about that quite a bit. So they can verbalize, they can tell you what they're feeling, so they might report heartburn a little bit more accurately. They can talk about a bad taste in their mouth, or you might notice that they've got bad breath. Actual regurgitation is much less likely in the older child because they can control it and they just swallow it back down, whereas a baby will probably just bring it up. And I've already said a cough, particularly at night when they're lying flat, could be a sign of reflux. Now, recurrent chest infections are sometimes put down to reflux as well. But there are, again, other reasons for that, problems with the airway that are associated with OA TOF that can lead to recurrent chest infection. So I'd be a little bit cautious about that. And I think that needs a more holistic workup and a multi-point workup before you simply say it's because of reflux. And someone asked about whether reflux can affect milk teeth. And yes, it can, because of the acid exposure on the teeth is damaging the enamel. But actually that reflux would have to be really quite bad to cause that. And I think normal dental care should keep those teeth in good condition, so cleaning your teeth twice a day and all the other things that you would do with any other child. And then another person asked specifically about the potential problems of long-term nighttime reflux. Now, actually, an older child, as long as they can protect their own airway, which all of us can, unless there's another specific reason that they can't, then it probably won't cause any specific problems or long-term damage. It might make them cough and disturb their sleep, which is obviously unpleasant, but not particularly dangerous. And it might give them bad breath in the mornings, but it wouldn't cause any specific long-term problems, it being at night.
Okay. Just a quick another question in the chat.
Yeah.
My daughter has had long gap and surgery. She's 9 years old now and is waking up most nights with reflux or crying in her sleep. She's using omeprazole twice a day. Is there anything further we can do to reduce this?
Yeah, that sounds like a really difficult situation. Obviously, I don't know the details of the surgery and details of the anatomy. And if that were my patient, I would be doing some quite detailed investigations on that. So probably a contrast study to look at the shape of the lower esophagus and the stomach, looking to see the position of the stomach as well, because that may have been pulled up into the chest partly. And doing a pH and impedance to quantify that and see where we are with that. There are other things as well as omeprazole. Now, I'll say this a little bit later, but it's important to remember that omeprazole and its sort of cousins, the PPIs, it's not an anti-reflux medication. It doesn't do anything to stop reflux happening. All it does is reduces the acid in the stomach, which is important, of course, but it doesn't stop reflux, and that reflux will continue. There are other things that might reduce reflux. So Gaviscon actually can be quite helpful in some people, certainly in reducing the symptoms. Although it's quite anaesthesia, I think, isn't it? So children often don't like taking it. But that can help. Changing the times that children eating less and more often can be a helpful way of controlling that. And we'll come on to this at the end. Surgery is sometimes a good option in children with a reflux that isn't controlled with medication and other means.
Okay, great. So we'll go back to the pre questions now, so that we have collated, and Duncan will take it from here for a little bit.
Okay, thanks, Trace. And Ian, thank you for those kind words that you said at the start. Much appreciated. So our next question is, what is silent reflux?
Yeah, so really tricky one, that, isn't it? Silent reflux, its very name suggests that it's silent, and so if it is truly silent, then there's no symptoms. Although actually, generally speaking, the term silent reflux is described for gastropharyngeal reflux, so reflux that's coming back up into the mouth. So it can give you a hoarse voice, give you bad breath, as I've already said earlier, bad taste in your mouth. And how do you manage that? Well, that's quite difficult, isn't it? And I'm generally speaking guided by a patient's symptoms. And if there's no symptoms, then there's very rarely a problem. And if there isn't a problem, then all I could do is make things worse. So I don't go looking for silent reflux because I don't think it's a problem. But if there are issues that are happening without the usual symptoms of reflux, like heartburn, then it's worth looking to see whether reflux could be a cause of the problems. And I'm thinking about things like chest infections, for example. I hope that helps. Silent reflux is a really tricky thing to talk about, and I know that people will get very worried about it. But generally speaking, like I say, I'm guided by symptoms, and if there's no symptoms, I don't think you need to worry too much.
Okay, that's great. Thank you. Can it be managed without medication or surgery? I mean, you've sort of answered it anyway, but
yeah, this question was absolute dream question for me. I think some of you will know that myself and a colleague, Nigel Hall in Southampton, are preparing a randomized control trial looking at the use of omeprazole after esophageal atresia repair to try and prevent anastomotic strictures, and whether all babies should have that to reduce anastomotic strictures. And the problem with that is so many babies end up on omeprazole or another PPI for reflux. So we've spent quite a lot of time working out an evidence-based flow chart or pathway for the management of a baby. This is only under ones. A management of a baby who has symptomatic reflux. And actually, like I've already said, a PPI, omeprazole, esomeprazole, pantoprazole, lansoprazole, they're all essentially the same thing. Doesn't do anything to stop reflux. It just reduces the acidity. And there are things that you can do to reduce reflux. So smaller, more frequent feeds, positioning during and immediately after feeds, feed thickeners, Gaviscon, are all things that you can do that will help and reduce reflux and potentially avoid medication. That said, a busy doctor, a busy surgeon, it's much quicker to just write a prescription for omeprazole, isn't it, than to go through all that advice, arrange to see you again in another 2 weeks, and so a huge number of babies and children with esophageal atresia end up on a PPI, and a lot of them it's very, very helpful, but some of them could probably stop it and could probably avoid it altogether if other measures were tried first.
Okay, that's great. Are there any other medication options to like omeprazole, lansoprazole?
Well, yes. So the proton pump inhibitors, PPIs, the list I just gave you of medications are relatively new medications. Probably when I was at medical school, they started being used. And before that, we used to use something called ranitidine or cimetidine, and they worked in a slightly different way. They had more side effects because they weren't quite as targeted in their course of action. And we don't use them anymore because they can cause problems with heart rhythm. So they're not generally used anymore. Other medication, there's other antacids out there, some of them very simple antacids that just use something like calcium carbonate to neutralize the acid in the stomach. And they can be very effective as well. They're very, very simple, very cheap. But PPIs are by far the commonest used because they really do work very, very effectively in blocking the acid production in the stomach very reliably.
Okay, thanks for that. Just one question, and then I'll pass over to Trace and we'll do some more because I know there's lots of people putting questions in the chat room, but we'll come back to those towards the end if we've got time. One lady's put, if a baby has omeprazole since birth, how does their stomach adjust over time naturally to manage the acid?
Yeah, so that's a really good question, and I'm going to talk about the long-term effects of omeprazole a little bit later on. So I will come back to that.
Okay, that's great. All right, Trace, I'll hand back over to you.
Great. Okay. So like Duncan said, there is quite a lot of questions in the chat, and it's very much specifically about omeprazole and just those types of things. So I think we are going to cover it just so that the attendees do know. So our next question is: should all OA TOF children be on omeprazole?
No, is the answer to that. Well, I say that's my opinion. And actually, if you look at various guidelines, including the European Society for Paediatric Gastroenterology and Hepatology, they say that all children with esophageal atresia should be on a PPI for the first year, and then they should have a pH and impedance study before the medication is stopped. I disagree with that, and I disagree with that on the basis of my understanding of the published research in that area, and I disagree with it on the basis of my clinical experience of many dozens of children with esophageal atresia. They don't all need to be on a PPI, and they certainly don't all need to be on it long term. Some of them do, and we'll come back to that, and that's fine if they need to be, but if they don't need to be, I think it should be stopped. If you look at cohort studies, so studies of large groups of children with esophageal atresia, those children who are routinely treated with omeprazole or another PPI have a higher incidence of anastomotic strictures than those children who are not. Now, I can't be confident that that's not for some reason like the children who have a more difficult anastomosis that's more likely to stricture are more likely to be given a PPI, and therefore it's not a fair comparison. But certainly evidence that we have at the minute is that PPIs don't help and may even make things worse with regard to anastomotic strictures, which is why I would only use them in the context of symptoms and treating specifically the symptoms of reflux.
Okay. Okay. So the next question is: what would be a trigger for starting omeprazole? Would it be esophagitis? Mm-hmm. And there's also about a question in the chat which says, doesn't silent reflux cause esophagitis? Mm-hmm. So a little bit of a link.
Yeah. So yes, silent reflux can cause esophagitis. You can, if you scope and biopsy someone, you can find esophagitis without any symptoms of reflux. It's a tricky thing to know how to manage that. What would be a trigger for starting omeprazole? For me, is if other measures don't work, and I would like to see those other measures that we've already discussed. So in an infant, feeding them less, more frequently, positioning them, trying some feed thickener before we resort to medication. Would esophagitis necessarily be a reason to start a PPI? Yes, if it was more than very mild esophagitis, I think I probably would, because chronic esophagitis can lead to what's called metaplasia, where there's changes in the cells that line the esophagus, and then that can lead to something called Barrett's esophagus, which can, doesn't always, but can then progress to a type of cancer of the esophagus. Now, the evidence for that happening in esophageal atresia is limited, and the honest answer is we don't really know what the risk is. There's certainly a very biologically plausible connection there, but we haven't demonstrated that in clinical practice yet. It doesn't mean it's not there, but we haven't proven it yet.
Okay. So when and how can we stop the medication then? So if you've been on it since birth, then when?
Yeah. Yeah. So it's difficult to know, isn't it? Because if you have problems and then you start on medication and the problems stop, how do you know when you can stop the medication? And the answer to that is you don't without trying. And so sometimes what I like to do, if I've got a young child who's been on a PPI, I just leave their dose as is. As you're aware, as your child grows, you need to increase their dose because we dose on weight generally. And so if you have a child who weighs, say, 10 kilos and you leave the dose the same as they grow to being 15 kilos, they're on 2/3 of the dose that they were on before, effectively. So it's quite a good way of weaning a dose down. And if the symptoms come back, then you can just start it again. It's as simple as that. And actually, PPIs work almost instantaneously. So you can do that and restart, and they will have the effect very quickly. In an older child, you can't do that because it's not growing fast enough to really have that effect. So you could try reducing the dose, see if the symptoms recur. If they don't, you can reduce it further. And if they still don't, then you can try stopping it and see how you go. And then there's a question about surveillance and how often we should be looking for problems with with reflux. Sorry. Now, my practice, and this is my practice, and I know other people have different opinions on this, is to not do endoscopies and biopsies or other tests looking for research unless there are symptoms, because I think you're looking for a problem that probably isn't there. Accepting what we've already said about silent reflux and the possibility of esophagitis. The only time I would routinely do an endoscopy is when a child is around 16 and we're thinking about transitioning them from my paediatric surgical service to the adult world. And I think that point is a good point to just see if there's anything going on in the esophagus that may need active follow-up, or whether we can give more of a reassuring bill of health during that transition problem. Yes, so someone asked about a long gap esophageal atresia and been told that they would always have reflux. Well, I mean, that's probably true, but then so does everybody. And so if it's not causing a problem, then great. Honestly, don't worry about it. I think if it was really long gap and really tight anastomosis, I think you probably are going to have symptomatic reflux that needs some help, likely medication. But if you're not, then really don't worry about it. Don't go looking for a problem if there isn't one apparent.
Okay. I think, again, this is a few questions in the chat, but is omeprazole another PPI safe long term?
Yeah. And a really good question, a really obvious question. Having your child on any medication for a long period of time is naturally going to be a concern. And the answer to it is yes, it is safe, although that's a slightly qualified yes. There were concerns that long-term use of a proton pump inhibitor can cause tumours, specifically something called a gastrinoma. Now, the reason for that is that internally, all of our systems are regulated with feedback loops. And the thing that causes your stomach or encourages your stomach to produce acid is called gastrin, and that's produced by cells, G cells, in the intestine. Now, if there's no acid, then you can imagine that gastrin is going to be pushed out harder and harder and harder to try and make the acid come, but it's never going to come because you're blocking the ability. And if you overstimulate a cell, you can then lead that to go out of control and start to grow on its own, which is why there was this theory that long-term use of PPIs could lead to gastrinomas. And I think that there was a rat model that showed that, but it's never been seen in humans, to my knowledge, despite many, many years of using PPIs over a very, very long time. So no, I don't think you need to be worried about it causing tumours, which is a very significant reassurance, I hope.
Yeah.
But there are some studies that do show an association with problems, including some gastrointestinal infections, including Clostridium difficile, which I'm sure you've heard of, can cause problems in hospital patients, can be very, very serious. And it can also cause some problems with electrolyte and vitamin deficiencies because of the change in the physiology of your digestive system by reducing that acid there. But what I would say is, as with everything that we do in medicine, it's a balance of risk and benefit. And if you have problematic reflux that is well controlled on a PPI, then I think those benefits will vastly outweigh the potential risks, as long as you're aware of those risks and can look out for the symptoms, which can namely be anemia, really, for this vitamin B12 deficiency is a particular problem. And I would encourage you to carry on with that medication and not stop as a result of those risks if it's helping you. That said, if you don't need it, then you should stop, because I don't think anybody should be on medication they don't need in the long term for obvious reasons. Someone asked about long-term high-dose proton pump inhibitor and an ongoing sore throat. Now, that's quite difficult to put that together with gastroesophageal reflux, because if you're on a high-dose PPI, then you wouldn't have acid reflux, and acid reflux would be the only reason that reflux itself could give you a sore throat, I would have thought. So I think you probably need to be looking for an alternative explanation for that sore throat. But maybe just discuss that with your family doctor, with your GP, might be the best port of call. Because of course, children who have esophageal atresia are not in any way immune from all the other things that children get.
Okay, I think Duncan's going to take the next few questions.
Yeah, my camera comes back on. So, can I use probiotics with a PPI?
Yeah, you can. There's no particular reason not to. Actually, those probiotics will probably work more effectively because there's no acid in the stomach to kill the good bacteria that you're taking in those probiotics. So yeah, no problem with a PPI. That should be fine.
That's great. And can this mobility affect the whole GI tract?
Well, the honest answer to that is yes, it can. And you can have a very severe dysmotility that causes a condition called pseudo-obstruction, where the gut just doesn't work. But that's not usually in association with esophageal atresia. It's a separate issue, which I suppose could happen in a child who was born with esophageal atresia, but that would be extraordinarily unlucky because it's quite rare. Esophageal atresia causes quite localized dysmotility within the esophagus, partly because there's a scarred area there, so there's not normal muscle for a section of it, and partly because that disruption in the esophagus means that the nerves don't travel along, so there's not quite the same coordination along the length of the esophagus as there is in children or adults who haven't had esophageal atresia. So usually it wouldn't affect elsewhere, and the question was in the context of delayed gastric emptying, and actually I wouldn't associate that with the esophageal atresia. And someone described their child preferring to eat standing up, and finding that was easier for him both to eat and less prone to reflux. And that sounds very much like it's dysmotility related to me. And reflux may actually be a bit better if a child stood up, because then their stomach's not squashed, and everything's in a straight line. And if that's what works for you and your child, then carry on. Although I can imagine the problems that would cause at school if you say that he has to stand up in the dinner hall. They don't usually like that, do they? But yeah, if it works for you, absolutely fine.
Now, being a teacher who has been on lunchtime duty many a time, you often say, sit down. So yes,
Yeah.
I can understand. I can relate to that one. Okay, so how do you feed a 1-year-old with dysmotility?
Yeah, so I read this, and I'll be honest with you, my heart went out to you, because my answer to that is with very great patience, because I know weaning sometimes is not easy, and I know that it's harder in children with esophageal atresia, and harder still if they have significant dysmotility. It can be a real problem, and the problem is that small children don't have the self-control and the self-awareness that we have of knowing that if they eat fast, then they're going to cause themselves problems. They just know that they're hungry and they want to get that food in, and so they go for it until they get a problem. And that's really difficult. And all the things like encouraging them to chew carefully and taking sips of water between mouthfuls is not going to work in a 1-year-old, is it? We all know that. So you probably just need to be realistic about what they're going to be taking. So instead of giving them 12 to 18-month-old purees, you might still be giving them 6 to 9-month-old purees, and going slow with that, and keeping them on a looser texture. But do be reassured that this will get better. It may take a few years, I'm afraid, but it will get better. And it's a pattern that I see time and time and time again in my TOF clinic, where you have young children, toddlers particularly, who are having real problems with the dysmotility. We've excluded a stricture. We know their esophagus is widely patent, but they're still having problems. And then usually around about school age, the things get better. And I think it's because the children develop that self-control and that self-awareness, and they understand that if they do certain things, they're going to have a problem. And so they stop doing them and they start doing the things that help. And it does get better. I don't think it's because the dysmotility goes away. I think they just manage it better themselves.
Okay, that's great. And finally, reflux following a gastric pull-up.
Yeah, okay. So gastric pull-up is, for those of you who don't know, is an operation for very long gap esophageal atresia where it's not possible to reconstruct the esophagus using the native esophagus. And so the stomach is mobilized and brought up into the chest, usually with an anastomosis in the neck. So actually gastroesophageal reflux is no longer possible because there is no esophagus, and because you don't want to leave a short section of esophagus at the top or indeed the bottom, but you want to actually remove any residual esophagus and make an anastomosis high up in the neck. They work better if you do that. But you can get regurgitation directly into the pharynx, which can be unpleasant and difficult. And there's no anatomical valve there like there is at the bottom of the esophagus to reduce that. So there's a real problem. But what I would suggest you talk to your surgeon about is when you've done a gastric pull-up, you want your stomach to stop functioning like a stomach, and you want it to function like an esophagus. So you want the food or the drink to go through the stomach very quickly and not be sitting there in the chest. But sometimes it can sit there in the chest, and that can get bigger, and the chest and the stomach expand within the chest. And I've had a number of children who I've inherited from my predecessors where I work, who have had this really significant gastric dilatation within the chest, and that causes real problems with them, with this just constant regurgitation. And there are things that can be done about that, either improving the emptying of the stomach to make sure it doesn't expand in the chest, or actually by narrowing the stomach down to encourage it again to work like an esophagus rather than working like a stomach, but up in the chest. I hope that's helped that question. I'm sorry to hear that you're having problems after that.
No, that sounds a bit great. Thank you. Trace, do you want to ask a couple of questions from the chat room? Because we've got a little bit of time left.
Yeah, that's right, Ian. And just maybe sticking with surgery then, and the option of fundoplication.
Yeah.
My daughter had a fundoplication. She has come off omeprazole following that fundoplication. She's 11 years old. And has, minor symptoms every now and again. So I think there's a couple of questions. One is this operation a permanent solution to acid reflux? And how often would you, she was having maybe endoscopies every 18 months previously. How often would you recommend an endoscopy following a successful, what appears to be a successful fundoplication surgery?
Yeah. Okay. So there's a lot there. So just for clarification, for those of you who don't know, fundoplication is the commonest anti-reflux surgery that we would do, and that aims to recreate the valve at the bottom of the esophagus where the esophagus meets the stomach, which, as I said at the beginning, is likely to have been distorted by the esophageal Atresia surgery. It can be a fantastic operation. It can be a real game changer. If reflux isn't controlled with medication and the other non-medication options we've discussed already, then surgery probably should be considered. The trouble is that it's not a perfect operation. The stomach is often small in children with esophageal Atresia, even later on in life, and maybe distorted, pulled up, so you have less stomach, less of the what we call the fundus of the stomach to work with, making it harder to do the surgery and making the surgery more likely to fail. And the other thing that puts me off doing fundoplications very often, I do them sometimes for children with esophageal Atresia. Some units will do them in as many as half of children with esophageal Atresia. I'd probably do it in about 10, possibly 20% of children. I can think of a few children that I've done a fundoplication on after esophageal Atresia repair, but not that many. Probably single figures still, and I've probably managed 50 children with esophageal Atresia in the last 8 years or so. So it's unusual for me to do that, whereas other people are much more likely to do it. I think that if you do a fundoplication in a child who's got significant dysmotility, then you're quite likely to make things worse, and you could change them from being able to eat relatively normally to not being able to eat solid food at all, which is a real problem. But that said, if there's an anatomical problem, then I think an anatomical solution is a good idea. So if they have something like a hiatus hernia, where the stomach's pulled up into the chest, then actually mobilizing that stomach, bringing it back down into the abdomen and doing a fundoplication can be really, really effective. And so in carefully selected cases, it can be really, really good. But I certainly don't think all children should have it. There are other modifications to fundoplication as well. So the commonest version of fundoplication that we do is something called a Nissen's, where we wrap the stomach all the way around the esophagus, called a 360-degree wrap. But there are other ways of doing that, and you can do a partial wrap either around the back of the esophagus or across the front of the esophagus, and they might actually be better for children with esophageal Atresia because of the dysmotility, because they cause less of an obstruction at the bottom of the esophagus. Unfortunately, they're slightly less effective at reducing reflux too, but the perfect fundoplication will leave you with just enough reflux to be able to burp and be sick if you have a tummy upset, but will stop you refluxing and still allow you to swallow. And it's very difficult to do that. So you're probably not going to completely eliminate the reflux. So actually just reducing it to a more manageable level might be a more realistic aim. So those partial fundoplications may be a good option.
Okay. There's quite a lot of questions in the chat surrounding like omeprazole, side effects of omeprazole. What about osteoporosis risk in later life?
Yeah. Yeah, that's right. So the electrolyte abnormalities can cause osteoporosis. There is an association. It's not necessarily a causation, but there is an association between osteoporosis and proton pump inhibitors. So I think, like I said before, that shouldn't be a reason not to take PPI if it's helping. If you're troublesome reflux and PPI is helping, then keep taking the PPI. Just be aware that there are these potential issues. Now, that osteoporosis is much later in life, not out with childhood, and there are things that can be done. I think it's called a DEXA scan, although you need to check with your GP. There is a relatively simple test that can be done to look for osteoporosis. If there is osteoporosis, then there's other supplements that you can take, vitamin D and calcium, for example, that can reverse that. So yes, it's a concern, but if you're aware of it and you look out for it, then you can mitigate it.
Okay, and that's the same for the brittle bone question as well then, yeah?
Yeah.
Okay. Okay, just go over to Duncan. He'll ask a few more.
Yeah.
Okay, so we've got just over 5 minutes left, Ian. So it's going to be a bit of a rapid fire sort of question, and see if you can answer it in a few words, because there's quite a lot of questions. So if we can get through as many as we can, that'd be great. Obviously, we're not going to be able to answer in full detail, but obviously, if you need to say it longer, you take it longer to answer. So the first rapid fire question: can reflux affect your oxygen saturation at night?
No, not directly. So reflux can cause chest infections, particularly in very small children, babies. But I think if your oxygenation is dropping overnight, then I would be very cautious about ascribing that purely to gastroesophageal reflux.
Okay. A child that's 8 who's on 20 milligrams of omeprazole is waking up thirsty at night. Is that a sign of reflux that might be out of control?
No, I don't think so. I've got lots of nieces and nephews, and quite a few of them say they're thirsty at night. I don't think that that's a symptom of reflux particularly.
Okay. Another lady's worried about her 2-year-old son with staining on the gum lines, and the dentist is adamant that it's from nighttime bottles. He only drinks water apart from his bottle, and they limit his intake in sugar. Will that affect his second teeth?
Well, I would certainly defer to your dentist for anything to do with teeth. But no, staining on your milk teeth shouldn't affect your second teeth. But if he's advising not to give that nighttime bottle, then I would probably follow his advice, because he knows a lot more about teeth than I do.
Okay. You also mentioned Gaviscon as a way to actually reduce reflux. Is that true? Because some people think that acts the same way as a PPI.
No, definitely not. Okay, so what a PPI does is, so PPI stands for proton pump inhibitor, and the proton pump is a protein that is embedded in the lining of the cells in the stomach, and what that does is it moves acid into the stomach actively, and what a PPI does is it directly turns that mechanism off. So it turns your proton pumps off, so your stomach can't produce acid. What Gaviscon does is that there's infant Gaviscon slightly different from adult Gaviscon. We'll talk about adult Gaviscon. Adult Gaviscon's got something called an alginate in it, which is derived from seaweed, and it neutralizes the acid that's already there, but it doesn't stop the acid being produced. And it also coats the esophagus. So as you reflux, the alginate comes up, coats the esophagus, and prevents the acidic reflux from hitting the cells of the esophagus. So they work in completely different ways and do completely different things. I hope that helps.
Okay. Another quick one. I think we've answered this anyway, but we've got PPIs taken daily, and obviously they're thinking about trying to wean off them. Are there any rebound effects if they suddenly stop using it?
Yeah, so that's a good question. And there are some, and someone else asked about whether long-term use of a PPI can affect the stomach's ability to produce acid. It can cause, so stopping the PPI can sort of cause a rebound effect, because as I've said earlier, there's this series of feedback mechanisms that stimulate and inhibit different processes in the body. And if you've blocked a process, then all the things that stimulate that process will be upregulated. They'll be pushing it, trying to make it happen. If you take away the block, then you can get a rebound in the acidity. So your stomach will still be able to produce the acid, and it may do it in excess. So sometimes you notice a rebound in that acidity on stopping them abruptly. So I'd recommend reducing it slowly. Like I said, wean as the child gets older, halve the dose. The person on the thing suggests taking it from daily to every other day. That's a very good idea, very good way of doing it. If the problems recur, then you can put the dose back up again.
Okay, thanks for that. Trace, do you want to ask one question?
Yeah, maybe something that hasn't been covered yet. Can you please talk about reflux in children who have had colonic interposition with no lower esophageal sphincter to stop reflux?
Yeah, so much less likely to have the problems that you get with the gastric pull-up, because you still have the stomach in the abdomen, which is where it should be. And the increased pressure in the abdomen compared to the pressure in your chest is one of the things that helps reduce reflux. So you can still get reflux into that colonic segment, which can be a problem. Although I think it's unlikely that that's going to come all the way up and be regurgitated. I would imagine that, I don't do colonic pull-ups myself, but I would imagine that will be under some sort of surveillance endoscopy as well, and monitoring that colonic mucosa that's in place of the esophageal mucosa for changes with regular biopsies.
Okay, great. So I'm just trying to find in the chat just if there's anything that sort of hasn't been covered. Maybe a quick one: omeprazole syrup or lansoprazole tablet, which one works better for babies under 6 months?
So it's the syrup or the tablet, which works better? No, they work the same really. It's just the syrup's much easier to get into a baby. If you've got the capsules, I hope you've been told this, you might not have done, but if you open them, then inside there are little granules, and those individual granules are coated, they were called enteric coated, and they're coated so that they release the medication at the right point in the intestine. And it's quite safe to open the capsule and give just the granules rather than trying to expect the child to swallow the whole capsule. You can stir them into yogurts, you can put them in porridge, anything that's sort of puree like, you can do that. But they won't dissolve, so you can't put them in a drink.
No. Okay. Another one about Domperidone. So we use Domperidone oxide Losec MAPS, a medication I haven't heard you mention. Is this for clinical advice?
Yeah, so we're not allowed to prescribe Domperidone anymore for much the same reason as the cimetidine, ranitidine. It can cause problems with the heart rhythm. And it causes a specific thing called prolonged QT, which can lead to life-threatening arrhythmias. So we don't use Domperidone anymore, or very, very rarely we use it, although children who are already on it will carry on with it. But you probably should ask for an ECG or a cardiology review if you've been on it for a long time, because of that reason. It can be really, really effective. I miss it it was a really helpful medication. What it does is it's what we call a prokinetic, and it stimulates the intestine to work, so it helps the stomach to empty.
Okay, Iain, Trace, thank you for tonight. It's been great. Iain, particularly, thank you for answering so many questions from the chat, which obviously you haven't seen in advance. And obviously, thank you to everybody who submitted all their questions well in advance. And apologies for all those people who's got questions that we haven't had chance being able to answer.
So if you would like, I can type some answers to those questions that have been unanswered. If that's helpful, I'll just spend 5-10 minutes doing that now. If you'd like, will you be able to access them afterwards? Is my only question.
If we download the questions and send them to you, we could probably get them out.
We could perhaps publish it in Chew, perhaps, or you could email responses to ourselves, Iain.
I think if we, yeah, I mean, it may be just do what you can for 5 minutes, Iain, and then,
I don't know whether they'll disappear at the end of the call. That's the only thing. Yeah,
I think they will once we actually end the call, but until we end the call, then they'll be okay. So if we leave the call live for 5 minutes, I'm happy to stay on for 5 minutes.
Okay,
and answer a bit more. So for those people who are going to leave us, thank you very much for joining us. Can I just make you all aware that we've got a big event going on the 18th of November at Great Ormond Street. If you are interested in coming to that, there are a lot of speakers at that event. However, seats are limited for that event because of the space capacity that we've got within the room. Obviously, please go to our website, book on now, because, like I say, it's filling up rapidly, and obviously, it's going to be a great event, and it's obviously our first face-to-face event properly in about 4 years since COVID hit. So it'll be great to see lots of people again and actually get together. So, Iain, thank you for giving up your time, and obviously the next sort of 5 minutes, it's answering all the questions that people are typing in there. I mean, if you want to just stay on screen and answer them live on screen rather than typing, if it's quicker.
Yeah, I mean, I can. I've probably got another 5-10 minutes. Yeah, so I've got them here. So I'll just run through them.
Yeah, if you just run through them, and we'll just let you talk. If that's all right.
Okay. So gastric pull-up is now fed 16 hours a day by his jejunal tube. Can this feed really affect how bad his reflux is, even though he isn't fed into the stomach? So, his stomach will still, up in the chest, be making some secretion. So he will still have some possibility to regurgitate into his pharynx, as I described earlier. But the jejunal feed should make that much easier, because that will be going in further down. So you shouldn't be getting feed coming back up into his mouth unless he's got some really significant dysmotility, which I think you need to see your surgeon, probably a gastroenterologist, about. So that probably should exclude feed reflux, although, like I said, his gastric secretions may still be regurgitated. Then someone advised to manage dysmotility. Well, really, like I said before, just with a lot of patience and a lot of realism about how well that esophagus functions. So drinks with meals, chewing carefully, but if they're too young to do that, then just realistic about what they can eat, and using purees judiciously would be how to go about that. And don't give up, because it will get better with time. Barrett's esophagus, it's a really thorny issue, really difficult to know when or how often we should ask doctors for a test. My practice, as I've said already, is just to do one check endoscopy at 16 and not before that. Even then, if we find any changes in the context of esophageal atresia, we don't know what to do with it. We don't know whether that is the same as those changes in someone who hasn't. So the honest truth is we don't know. My practice is to check once at transition to adulthood. Schleimer, I think I've said your name right. Your baby's 16 months old, omeprazole twice a day. Tried a few times to stop his omeprazole every time he did it. After about 3 days, started vomiting coffee ground. So I'd have temperature. Twice a year in the hospital. Is this normal, or it means there's severe reflux? Well, it sounds like his omeprazole is doing the job. So I would recommend you carry on the omeprazole and don't try and stop it for probably a little while, maybe another year or so, if that's happened. Can't quite put the temperature onto reflux, but certainly the coffee ground could be due to severe esophagitis. If you find that the PPI is helping, and when you stop it, he's getting symptoms, then leave him on it. That would be more her, sorry. No, it is him. You do say his. I would leave him on it. David, you ask about probiotics. Because PPIs inhibit the production of stomach acid, do you think this would affect the gut biome, giving rise to spectacular wind? Yes, it could do. It will affect the gut biome because your acid there is a sort of first line of defense against bacteria you swallow. So it will affect the gut biome. Whether or not that causes wind, it's very individual. If probiotics help, then fantastic. No problem with you using them at all. Any tests available to check motility in esophagus? Yes, there are. There are a number. My colleague at the Evelina has a particular interest in intestinal motility, and so we have started doing a number of investigations, from formal what's called manometry to a sort of more sort of less sophisticated way called endoflip, where we can look and map the motility in the esophagus, and getting some interesting results on that. So yes, there are a number of ways to look for motility, and particularly if you've excluded a stricture and they're still having feeding difficulties, then looking for dysmotility can be quite enlightening. Tomorrow, you're asking the maximum dose of omeprazole recommended children. No, 1 milligram, you can double that. 2 milligrams per kilogram is generally speaking considered the maximum, but then you can even go beyond that in certain circumstances. Anonymous, your daughter had really bad reflux as a baby. I'm sorry to hear that. Hospitalized many times with desaturation of Brady. I'm sorry about that. Always been put down as reflux, but after hearing this wouldn't affect it directly. Should I challenge this, please? Well, look, you can, in a baby, have what I have described as acute life-threatening events, which is, essentially a desaturation. Could be associated with bradycardia, could be associated with what's called an apnea, where they stop breathing. So it's possible that is what's happening each time. But I would be cautious of just saying, oh, it's reflux, unless you've tested that. Has she had a pH and impedance study to quantify her reflux and to associate episodes of reflux with the symptoms that she's having? And I think if she hasn't, then you should probably be a bit careful about ascribing that to reflux. So I think, yes, you probably should challenge that. Can reflux cause gagging and a fever? I assume that's a fever.
He's feeding aversion.
Feeding aversion. Yes, I see. He's clarified that further down. Yes, yes, it can. So if, particularly in small children, babies, if you get stuff coming into your mouth that you can't control, then yes, you can gag on that. And if you're having an unpleasant sensation every time you feed, then sure, you're not going to want to feed. So yes, it can. Can omeprazole cause upset stomach gas? I think I've said that already. Yes, it can, by affecting the bacteria in the gut. Daughter have fundoplication doing well. Can you stop the lansoprazole? Yes, probably. Talk to your doctor, talk to your surgeon. Maybe try weaning it like we discussed before, but hopefully, yes. If she's had a successful fundoplication, hopefully you won't need medication.
If you look 2 questions further down, Ian, you did the operation.
Oh, yes, yes. I know. I know who that. I won't say her name. But yes. And I hope all is well, because unfortunately I don't look after you anymore. But remember you fondly. What's the process? We want to make sure everything's okay. What should be the next follow-up? Well, talk to your surgeon that's looking after you now. And if there's no symptoms, then I personally wouldn't be worried about that. Some people do have a slightly more proactive way of going about things, and will go looking with endoscopy more regularly. I don't do that because I don't think the evidence there for it. Other people feel differently, and I respect that. It's just not what I do. Okay. Yes, Susie, do I have an experience of reflux causing additional stricture lower down in the esophagus? Yes, I do, and I'm managing a child who has a very difficult stricture, probably as a result of chronic reflux, not in the context of esophageal atresia. Once you've got an established stricture, it can be very difficult to manage, and you also need to remember that there are other causes of distal strictures in the esophagus which would need to be excluded, which can be associated with esophageal atresia, including having cartilage in the wall of the esophagus. So you'd need to look for that as well. I think what we call a peptic stricture, which is a stricture associated with reflux, is an indication for surgery. I think that would warrant a fundoplication. Good. Challenging DSATs, no test, nothing particular. Yes, I think you probably should. I think you probably should challenge that actually, and have that investigated a bit more in detail. Okay,
Iain, thank you for doing that. Has been a huge help, and I'm sure everybody who's listening has thoroughly enjoyed tonight. Looking at all the messages, and thank you to everybody who said thank you, particularly to you for being so informative with everything that you said, and thank you for giving up your time for tonight. So thank you very much. Obviously, we have the usual questionnaires going out, so please do fill them in because it does help us to actually do these things in the future. So thank you all for your time, and hopefully see some of you in London on the 18th of November. Thank you.